What's up, guys? I'm Zach, I'm Dr. Eyeball MD. Day in the life, ophthalmology resident. Let's go. Alright, still dark out. Driving into the outpatient surgery center. There's surgery all day today. I just saved time in the morning by keeping this sea salt spray in my car. I just spray it on my hair. And that way I don't have to fix my hair in the morning, and this pretty much holds it, so I just do this while I'm driving in. So it saves me like a little bit of time. My drive in when I'm at the
Turn
Dallas
left
side
onto Ninth Street.
is only about 8 minutes, so it's not too bad. And when we leave this early, it's 6:30 right now. We really don't hit traffic, so it's not too bad. We have some pretty interesting oculoplastics cases today. We're in the OR the entire day, from 7 probably till like after 4 p.m. We'll be operating first in the outpatient surgery center, and then we'll go over to the main hospital, the county main hospital. But the first one is going to be an orbital decompression for thyroid eye disease. So people who get Graves' disease, if you've ever seen somebody with Graves' disease, you know how their eyes tend to kind of bulge out or be proptotic. Once that disease process kind of settles down, over about a year and a half, that bulging out will actually stop and kind of settle out to where it's going to be. But you know, things that can result from that are double vision. The eyes will be pointing in different directions, so they're seeing 2 different images. The proptosis, you know, so they're sticking out. Patients don't like that cosmetically, but it can also cause problems because the surface of the eye gets exposed because the eyelids don't cover it, and when you blink, you don't get a complete blink over the eye, and when you sleep, there's lag ophthalmos, so the cornea gets exposed and it's not covered while you're sleeping. So it can cause a lot of problems. So kind of the stepwise approach to fixing the thyroid eye disease is first to do an orbital decompression, and then you treat the misalignment issues with strabismus surgery or realigning the muscles. And then after that, you address the eyelids and fix ptosis or retraction, that kind of thing, anything that's left. So this first patient is we're addressing the proptosis by doing orbital decompression. So actually going into the orbit, which is the eye socket, and removing some of the bone so that it creates more space for the eye to kind of fall back in the eye socket in the orbit, and so it's not so proptotic, so it's not sticking out so much. And the attending I'm working with actually helped develop one of the approaches into the orbit that we're going to be using today. So we read the paper on that last night, me and the fellow. Another one of the cases we have is optic nerve sheath fenestration for people with bad pseudotumor cerebri idiopathic intracranial hypertension, which is basically just where the fluid around the brain and spinal cord, the cerebrospinal fluid, actually it accumulates, causes the pressure to go up, and it squeezes down on the optic nerve. So a lot of times we'll treat that with Diamox, but if that's not helping, or if they've had like a VP shunt with neurosurgery, one of the later line therapies for it is to do an optic nerve sheath fenestration. So the nerve sits in a little case, which is actually the same thing that surrounds the brain, the dura, and we'll go in through a superior medial approach, so we don't have to take off any of the bone or the muscle to get to the optic nerve, and we kind of track back around behind the eye, find the nerve, and then make a small little window. We make a small little window right in, there's a rack right there. People are out of the car though, so it looked okay. So we make this small little supramedial incision, go back to the nerve, and then make a window in that dura, in that nerve sheath, and that kind of relieves the pressure. And you can actually see like a kind of a gush of fluid of cerebrospinal fluid that comes out when you make that cut. That approach into the orbit, which is fast and it's a lot less invasive. You're not taking off muscles. You're not opening up bone, and you're not dissecting back underneath the cons. You just go back through the superior medial part of the orbit, hit the nerve, and then open it up. And he's done the case in 7 minutes before, so it's a good approach for it. So we'll do that as one of the cases too. And then we have some eyelid stuff too. So we have ptosis repairs, and some lower lid blephs. I think there's an ectropion as well. So a lot of good stuff today. It'll be a good OR day. Trying not to drink too much of that Monster so my hands don't shake while I'm operating from the caffeine, but I gotta stay awake. So we just did the first case. It was the orbital decompression for thyroid eye disease. So we started off, we did a lateral decompression, which is kind of cool. I'll show you an example in just a second of kind of what it was right here. So to demonstrate an orbital decompression, I made an orbit. This is your orbit, literally your orbit. Just kidding. So it's shaped kind of like this, like an ice cream cone, and it's sort of conical and it goes back and kind of tapers at the end. And then the eye sits in it like this, just like this hard-boiled egg. And just like that. And with thyroid eye disease, it's proptotic, so it's sticking out past the orbital rim like this. And so that's why patients have that look of like the eye sticking out and looking proptotic and kind of bulging. The goal of the surgery is to get the eye to sit more back in the orbit, further back behind the orbital rim. And the way that we do that is with the decompression. So we actually relieve some of the space, we remove some of the space in the orbit or the ice cream cone. So the way that we do it is, if you think of this as my right eye, so like this, the lateral part is here on the outside, the medial part is here on the inside. And so we start with the lateral part, and what we do is we go in with a drill, which is demonstrated by this electric toothbrush. And so the drill spins at 70,000 RPM, and we go behind the periosteum, which is the layer that covers right up against the bone. We peel it off over here on the lateral side. So I'll move the eye out of the way, just to kind of demonstrate. Because the eye does have a little bit more movement than the egg and the ice cream cone, so we have a little space here. So we go in with the drill, and we basically will just burr out along this rim and create some space by chipping away at the bone, just kind of shaving it off. And so that relieves some space on the lateral side, and so that's the lateral decompression. So we just the drill spins and kind of goes up against the inside rim there and just kind of burrs out that, or bores out the lateral wall of the orbit. And then we go on the medial side. Now the medial wall is much thinner, so we actually go in through caruncle. So right here, the little, the kind of pink spot right there, we create an incision. And so there's no skin incision. We go right through there, and then go in with some things that are similar to kind of like, they just grab bone basically, kind of like the scissors here. And so we grab the bone on the medial wall and just kind of pull it away, chip it away. And it's super thin, it's paper thin, so we actually just take off part of that medial wall, sort of like that. And so now we're in the nasal sinuses. And so that allows that fat, that orbital fat that's taking up space in the orbit to kind of prolapse over into the sinus. And now we have all that room in the sinus for things to move that way and for the eye to fall back. And so the result of doing that, we're not actually taking bone from the lateral side, we're just shaving it down so that wall stays there. It's just thinner most often, but the result of it is that the eye actually moves further back as it falls apart here, but it moves further back in the orbit, and so it's not so proptotic, it's not so bulgy. And that's an orbital decompression that we use for thyroid eye disease. But we basically just burred out the side of the lateral orbital wall, and then we did a transcaruncular approach for the medial wall, so I actually cut in through here, went down to the medial wall, and you can get all the way back to the orbital apex that way and just debulk some of the bone there. And her eyes, we just did the one eye obviously, so It's sat a lot lower, a lot less proptotic, so it'll be pretty good, and she'll get the next eye done, the other eye done next week. And so now we're about to do a repair for a lady who had orbital fracture with multiple surgeries, at least 4 surgeries. So she has residual inophthalmos, so the eye is actually sunken back, the opposite problem of the first patient we had. And then the lower eyelid is turned out, has ectropion. So we're going to do an alloderm graft, a lateral tarsal strip. So it's kind of a lot of stuff going on for this lower eyelid, kind of complicated case, so it should be good. Alrighty, so it is about 10:15 in the morning. We just finished the second case, which was the inophthalmos case, so the eye was sunken back in the eye socket. So we actually went in with alloderm graft, which is like a dermal matrix, so it kind of acts as like a filler up under the under eyelid to kind of give it a little more space. And then we brought up the eyelid with the lateral tarsal strip, and we did a small lateral tarsorrhaphy to kind of give it fullness and then bring the eyelid into the proper position. She had some ectropion as well. And now we are about to do a 4-lid blepharoplasty. Then we're going to remove a small lesion here in the lateral campus. So it should be a good case. And also going to do a brow lift. So this will be the 3rd case. And we have one more here at the Outpatient Surgery Center, and then we will head over to the main county hospital and do 4 more, like 3 or 4 more cases there. So it should be good. Let's go. So we did the 4 cases, we finished the last 2. We did the 4-lid blepharoplasty and a brow lift through the upper blepharoplasty incision. And then the last one did a temporal artery biopsy, which we would have done in clinic, but the lady was really anxious, so she wasn't gonna be able to do it in clinic. So now we drive over to the other OR in the other hospital, and we have a couple cases there. So we'll do that. Should be good. Now I'm walking over to another hospital. It's not a close place to park. We'll start off with the optic nerve sheath fenestration. And we'll do the superomedial approach. Get back to the nerve, open up the nerve sheath. It shouldn't take that long. Don't have to take off any muscles, don't have to remove any bone. So it's a good way to get to the nerve. So we'll do that first. So oculoplastics is pretty interesting because on one hand you have a lot of cosmetic procedures and you're just kind of making old people's eyelids look better, which is good. And then on the other hand you have people going blind from things like thyroid eye disease, causing orbital compartment syndrome, and all kinds of terrible eyelid lacerations and things like that. So it's and then you can do surgery to actually help prevent people from going blind by operating in the orbit. There's a lot of breadth in oculoplastics. So we're actually, the 2 cases we're about to do, one is for eyelids and one is for a pseudotumor. Alright, so now we are finished with the OR. We did, the last case took a while, so it's already 6:20, but we did bilateral ptosis repair, internal ptosis repair, mulerectomy, and then we did lower lid retraction repair. So we did another alloderm implant on both sides to bolster the lower lid, and then did a lateral tarsorrhaphy on both sides, as well as a lateral tarsal strip. So it took a little while, but it should turn out okay. So we'll see him next week, and that'll be good. Now we're gonna go home. Alright, that's it guys. Long day of surgery. Alright guys, I hope you liked it. Leave a like and subscribe if you did. I'm gonna take you on call with me next time. for a weeknight call. It gets pretty busy sometimes. I'm Zach with Dr. Opphel, and I'll see you next time.